Welcome, Piedmont. It's great to have you back with us. I'm Herb Aronow, and on the panel with me, Eric Sostemsky, Alyssa Alton, Wayne Batchelor, Adir Shroff, and Benita Shah. We saw your great work earlier in the day, and it's nice to have you back with us. Tell us about your case.
Herb, thanks very much for having us. Can you hear me okay?
We hear you beautifully.
Perfect. Well, thank you to the ACC for another opportunity, and greetings to you, Herb, and the rest of the panel. Just to start with, Michael, can we have our slides up, please? Thank you, and just to the next one. So before we start, once again, I'd just like to acknowledge our fantastic team. We have Dwayne Brown, Rodney Jackson, Donna Cord, Santasha Askew, and it's, without them, we would not be able to do this case or any of the other cases that we do to serve the patients here in the Atlanta, Georgia community. So thank you once again. I'm here with my good friend and colleague, David Kandzari. An honor and privilege to work with him. And we are going to show you an interesting case here in just a second. So let's move on to the next slide. So, Herb, this case that we have here is a 60-year-old man who has the usual risk factors, previous smoking, hypertension, hyperlipidemia, and was recently diagnosed with diabetes. And in an attempt to combat his diabetes, he started exercising more. And while he was increasing his exercise, he started developing progressively worsening exertional angina. He was started on some anti-anginals, but his chest pain became quite significantly worse. And so he was referred for diagnostic angiography. Next slide. We did that a few days ago. He was found to have a left dominant circulation and a very severely calcified proximal to mid-LAD lesion, which we'll show you just in a moment. And so the discussion here is going to focus on sort of the treatment of calcified lesions, and we'll go through a potential algorithm, and we'll welcome your thoughts from the panel on that as well. But another sort of curveball that got thrown to us unexpectedly last night with this particular patient was the fact that we tested him, as is routine for our inpatients that come down to the lab. We tested him for SARS-CoV-2 virus, and unexpectedly he was COVID positive. And so this raised some additional concerns. He had no symptoms. He had been previously vaccinated, no respiratory symptoms whatsoever, maybe a mild fever which resolved. But that also added another dimension to the case. But once you see the anatomy, you may agree with us that we felt, given the severity of his disease, it made sense to proceed here. So let's look, next slide, please, Michael. So here are the pictures from the previous diagnostic case a few days ago, and you can see in the left panel a quite severe, heavily calcified lesion. The middle panel, you see the IVUS catheter would not proceed beyond that heavy calcification, the sort of tram tracks that you see right in the middle. And in the more proximal segment of the vessel, there's this dense concentric calcification shown in the right panel there. So that's the case. And Michael, just go back one slide now, please. Oh no, forward, please. Forward one slide. To the next one. So here's how we've in general thought about dealing with heavily calcified lesions. And there are variations of this theme, but I think in 2022, most of us would start initially with intracoronary imaging, and then depending on the location, the depth, the arc of calcification, we then sort of decide on our treatment strategy thereafter. So I might stop there for a moment and invite Dave to comment, give his thoughts both on the anatomy and the procedural sort of strategy here, and then invite comments from the panel as well.
Terrific. Thanks again, Prashant. And Herb, Eric, and the rest of the panel, thanks for sharing your insights with us and being part of this program, enabling us to be part of the program too. If we can perhaps ask Michael Shivers too with our AV group just to show the angiogram today too, and we'll just revisit the anatomy with you, is that we have some options to us in part in line with the algorithm. Specifically, Prashant and I, and the COVID positivity would exclude this, but we talked about this would be a patient who would potentially be enrolled in the ECLIPSE trial, which is currently randomizing patients to atherectomy, in this instance orbital atherectomy, versus high pressure and sometimes repetitive balloon predilatation as a part of vessel prep for calcified disease. And then the other instance that we now have available to us is intravascular lithotripsy, and sometimes a combination of those therapies as well. And you can appreciate that in this instance, the most significant lesion has these classic train tracks of concentric calcification. But on the IVUS imaging in the panel that Prashant showed you, actually that segment was indeed more proximal within the LAD, and in fact this is a repeat IVUS today, just showing a 360-degree arc of calcification. So we'll pause here and perhaps review with you all on the panel with regard to your preferred strategies for the management of this disease.
Thanks, Prashant. Thanks, David. Really appreciate it. That IVUS from today, did you stop short of that tight stenosis then, as with the diagnostic?
Yes, correct.
Yeah.
The IVUS catheter would not cross beyond the lesion.
So let me, I don't want to detour for too long on this topic, but I think you mentioned it, and it was a curveball. So let's just talk for a second about the COVID aspect. I think we probably don't really know what the implications are of doing an intervention in somebody with stable ischemic heart disease who's asymptomatic but COVID positive. Benita, for some time, New York City was the epicenter in the U.S. of COVID. What were you doing with these cases? What are your thoughts?
Yeah, I mean, we've evolved so much since March 2020, and which is a good thing, but we still don't have all the answers, and there's a lot to still be, to be learned. Now that our staff are all triple vaxxed and most of our patients are triple vaxxed, it is hard to understand why there should be a potential clinical, an interruption in clinical care. But it is, if you test enough, which is what we're doing, we're still testing every single patient before they come to the lab. What do you do with the results is a big question. So I think, we weigh the risks versus benefits. This is a patient with a critical lesion and life-limiting angina and lifestyle-limiting angina, and proceeding is really the right option.
Dear, obviously haven't seen the lesion itself yet. Do we need to get across there and get better imaging? Do we need to predilate and get more information, or do we have enough?
Yeah, I think I'm pretty convinced already. The fact that it won't even go, even past a more proximal lesion, I'm pretty convinced that that disease is just continuous. It probably starts in that proximal segment. I think what I'm more interested in is where is the sort of the landing zone, or where is the healthy tissue in that LAD where because you're probably going to stent that whole proximal segment as well. Is it all the way into the osteum? Is it into the left main? It doesn't look like, looks like there's a nice...
I'll give you another view here, Adir. This may help too.
And Adir, just in the interest of time for the imaging, we IVUSed it again today as we discussed, and right at that first septal is a good landing zone for the proximal segment.
Yeah, and it's interesting, in the initial diagnostic view, there looked like there was some disease distally. I'm not sure if nitro was given or what, but things have plumped up considerably since the original diagnostic pictures, which gives you a better distal landing zone for sure.
Right. Wayne, did you think there was both superficial and deep calcification, and would that affect your approach?
Yeah, no, this is extensive calcific disease. The very proximal LAD looks like it's a good size and diameter. We can get that from the IVUS, but it looks like it's going to be at least 3.5 to 4 millimeters. And then there's just this diffusely calcified lumen in the proximal LAD, and you saw that it was really 360 degrees of calcification in that proximal vessel. It looks like the lumen is 1.5 or maybe 1.5 to 2 millimeters max, and then we haven't even seen the very tight lesion. But if you look at the radiographic image of the very tight lesion beyond the diagonal, it just certainly looks like it's going to be densely calcified. Yeah. So my thought on this is you have to treat the proximal segment, and you're going to have a strategy for dealing with that very tight lesion. recognizing that the patient might get a bit ischemic when traversing that tight lesion. And I'd be interested to hear what the team here is going to do. They're very experienced in this type of lesion, so I'm curious. But I'd be probably heading toward either orbital or rotational atherectomy myself.
David, did you mention the LV function? I'm sorry, I don't remember.
Yeah, LV function is normal.
Normal
LV function. And the ADP is 13.
Great. Alyssa, what are you going to grab first? What's your first step here?
Well, I think ultimately it'd be great to image this. So if your IVUS isn't passing, you're going to have to pre-dilate to get something down there, either IVUS or OCT. So I'd be curious to know if you can pass a balloon and what size.
So you'd like more info, more data, intravascular imaging. Okay, well, David, Prashant, tell us what you're going to do.
Just as a quick comment too, appreciate Benita's comments about the COVID positivity issue. I said to Prashant at the beginning this morning when we found out this information that if this were March 2020, we would have been postponing this for 2 weeks. And this is a case with accelerated angina and a high-risk lesion, as you mentioned, and so we're motivated to move forward. So our ambition, we have 3 options, of course, again, repetitive, high-pressure, non-compliant balloon angioplasty, plus or minus a combination with atherectomy methods, orbital, rotational, and then finally with intravascular lithotripsy. And our ambition first is to begin with just pre-dilating this discrete but very, very calcified mid lesion after the diagonal branch. And we're going to use a new technology that's just entered into the market with FDA approval. This is the ScoreFlex balloon from Orbis Niche and CSI, and it's a balloon catheter that, for those of you who remember the FX mini rail or poor man's cutting balloon, where there's a nitinol component, a wire component, but then you also use, with a short RX system, the wire outside and adjacent to the balloon as the second scoring element. That this is a 1.75 balloon, but what's also unique about it is that it's exceptionally low profile. It almost feels, when you run your finger across it, like a microcatheter. And more than that, the non-compliant balloon, it's rated at 20 atmospheres, and this 175, I believe, only grows to about 1.85, 1.87. One last element is you can see the very short RX component element of it, and that enables the adjacent wire to serve as the second scoring element. So we're going to experiment with this also, so to speak, to see if this will cross the mid lesion and at least give us more room for whether we want to image more or whether we want to try a lithotripsy balloon or other.
Dave, this is supposed to be more deliverable, I know. And how are you sizing this right now? And I missed which balloon you pulled. And you.
Eric, this is the 175, and I'll be surprised. You never know till you get there, of course, so you show up. But I'll be surprised if this does not cross. Prashant, there we go. So
you saw that it sort of went pretty smoothly through. I think there are a couple of things here. I think we're occlusive there, which is
I'm
why
going to go up.
Yeah, so you can go.
You ready
up there.
for me to go?
Yeah, go ahead. So the very short RX segment of this.
You can. Sorry to interrupt you,
go
Prashant,
ahead.
But you can see also the 2 elements.
I'm going to give you a fluoro there so you see it.
Sorry to interrupt you.
No, go ahead. But it's a very, very short RX segment, and I think that. Thank you. We're down there. Let's see, and you can even winged. It's going now. Let's take a little. We are. So we're through the right radial with a 6/7 glide sheath slender and a 7 French EBU 3/5 guide.
Let me ask you all, there were some comments as a next step as to whether we should do imaging, just to further clarify, but would this change your treatment strategy at all with additional imaging? For nodular calcification, which I think is fairly evident sometimes just under the angiogram, I'm more leaning towards atherectomy rather than lithotripsy, but this seems to be more superficial concentric calcification, at least on the front end, but welcome the thoughts of everyone else.
Yeah, I got a question for the panel. I mean, when you're pulling an atherectomy device, manipulating the lesion always leaves you a little bit more vulnerable. And so, a gentle predil and then rotational orbital atherectomy. Now you've used a scoring balloon. Is that going to change what you're thinking? Are you going to be more prone to something like IVL because you don't want to take rotational into a lesion you've potentially macerated? I don't know.
I think that's a good point. I think part of that discussion, though, is going to be informed by what we see here now on the IVUS. So our intent in this sort of initial predilation was to, get this IVUS catheter down to kind of get more information about what kind of lesion this is. Hopefully it'll cross now, and we'll get some more information about that, and we can decide. So let's see how the IVUS behaves. Still kind of getting stuck in there, maybe a little further than it got previously.
You're past the diagonal, which we couldn't go before, but
it's
we're
sort of
still
engaged in the lesion, but it doesn't want to
the
go
guide
beyond
really
that.
pushes back, doesn't it?
Yeah.
So the diagos looked okay.
Yes, I think so. So I think here we could sort of further predilate, or maybe see if the shockwave will go.
It's interesting when you guys think about CSI in this scenario. I worry when it's really tight like that, will you get the nose cone, the nose to deliver? I mean, we've had good luck with it, but sometimes when it's really tight,
Yeah, we can
sometimes
try.
it's
Do
a
you
little
want
bit
to
of a
take picture?
challenge.
Just to see
And
what-
IVL as well.
Okay, ready?
Is this
Yeah,
a
I
case
think
for rotoshock?
That's what I was considering, just given the tight lesion, would have considered, and the calcium proximally, would have considered rotational atherectomy up front, and then if not enough has dilated, or if there's still deep wall calcium on imaging, then going into IVL therapy. But now that you've done, scoring, and we can see whether or not a larger scoring balloon would create some more cuts. I will say that when I use a cutter or a scorer, I sometimes just use it just to create the cuts and see if another non-compliant balloon or a high-pressure non-compliant balloon would then deliver to be able to expand a bit more after the cut's been done.
That's a great comment. I mean, I think if you can get an IVL balloon down, you're going to be effective with it. It's just a matter of whether you can deliver it.
Yeah.
Oftentimes at this point, I'll switch out even just for a wiggle wire, which gives me a lot of rail to deliver it. And I think if you got that cutting balloon down a bit or scoring balloon down, you're probably going to get a larger scoring balloon down, or like you said, Benita, and then you could definitively treat that.
Right.
Yeah, I think there'd still be another opportunity to, this is a 4.0 shockwave. I was going to say, I think there'd be still another opportunity to get another device down there, a non-compliant balloon, and try, but it looks like this went across. So we're going to go ahead.
Hold on, when it came out. Hold on.
Okay.
Yeah, here we go.
So that's amazing. The
Yeah, that
IVL
is.
balloon went down, but the IVUS
not the
would
IVUS,
not.
I
That must
agree.
have been
Okay.
some
Nice
sort
work.
of,
Yeah.
I think
And
it's
obviously
forward.
you only have so many
Flip forward,
bullets in
come
your
down
gun
there.
with that balloon.
down,
How do you
no.
line up your emitters?
Yeah, so we're just going to try and get right. It's sort of seeding a little bit as we try there, David. There it is.
There we go. I'm going to deliver therapy.
Yeah.
Very nice.
Yeah, the advantage of IVL here is that you saw concentric calcium.
So we're pacing him too, by the way.
You're pacing, you said?
Yeah, so we had electromechanical capture there, and we saw a decrement in our waveform, and we were pacing him just as we went along there.
So that was our first cycle.
Do you want to do another cycle there?
Yeah, let's go up again there.
Looks like it's fractured, though. Let's do another one. Ready?
Yeah, we didn't finish the last cycle there.
Oh,
let's-
sorry.
Yeah,
Thought we did.
okay. Come down there, and then we'll
Okay,
just
yeah.
finish that one.
Do you want to
Okay.
talk about just your selection for sizing? And, we don't have the IVUS information. What are your
Can we-
thoughts on
Okay, there
selecting
we go.
the balloon,
It's
the
going.
IVL?
Yeah, so I think...
Hold on one second. Can we just see we're
Yeah,
pacing him here? Can
with-
you all see
can
how
s-
we're pacing him?
You can see the electromechanical coupling there on the screen there, and we're down. So your question there about the sizing. So typically, I think it's important to go as close to 1-to-1 for this. If your IVL balloon is undersized, I don't believe you get a good sort of acoustic coupling, as it were.
48.
And so in order for the acoustic sound waves to do their job, I think you really need to be as close to 1-to-1 as possible. Undersizing, I think you're not really doing anything there. Go ahead.
And what was your inflation strategy? Were you at 4 atmospheres?
Yeah, we're
Yeah,
at
I'm
4
at 4.
atmospheres. Yeah, just the usual.
We're pacing again. Can you see?
Yeah,
And
I don't think I've ever seen that before.
you really see a nice, and you see a
down.
little decrement of the blood pressure with the pacing, of course, about a 20-point decrement. But also, once we're done, I go up to 6 atmospheres. So we do go to 4, and then I go up to 6 before coming down. But the balloon clearly looks like it's expanding well.
Yeah, I think
You want to come back a little
yeah.
and just go all the way back?
We've done 3 here. Should we do one more? And then
wait for
4 at the proximal. 4 here and 4. You want to just go proximal?
So given that you still have some room to go with the IVL, would you do the whole segment, including the proximal landing zone, just to make sure everything
absolutely,
expands?
absolutely. Bonita, that's actually a really important point. So what often happens is you kind of get focused on the kind of main lesion at hand, and then you often forget the more proximal segments, which often are also calcified. And then what happens is you have a good expansion at the site of the main lesion, and then at more proximal portions, it's sort of a little bit underexpanded, or you kind of have that regret that, you should have. Let me bring it back a little bit more there. Go ahead there.
I think it's a great point, Prashant. I mean, I think it just speaks to the fact that you only have so many pulses you can deliver from a single balloon.
Right, and so we've used half. I think that's good there, don't you think?
And I think we're getting, maybe it's because we're in a large caliber vessel, but I think we're getting very fortunate here that there's a little bit of water seeding of the balloon, and yet we're able to go forward, because my rule of thumb is this balloon won't go forward once it's been expanded. So
Looks like you're probably hitting that really concentric zone of calcification.
right there.
That's what it looks like, yeah.
I'm still in awe that balloon crossed. I'm just going to say that again. I mean, that's phenomenal, that.
I mean, part of it, you wonder how much the Scoreflex helped as well initially. Just to make enough
You're
room.
making a good case.
Yeah, we went to 20 atmospheres with it, with a 175, and it just gets us to 1.8, 1.85 diameter, but it seemed to be enough.
I was just going to say that the economics of this are interesting. This is an outpatient, so
6 here.
you can use a couple of balloons and you'll get these additional payments. However, that's
6
true for
atmospheres.
Medicare patients, right? This is a 60-year-old. So are your local carriers covering IVL in Atlanta?
First.
Yeah. Oh, I'm sorry, Herb. Not yet. Not yet.
Should we come out?
Yes. But what's also, just to expand on that discussion, is what's also interesting for us is that we've seen, we have many, across our hospital system, we have many hospitals that do PCI without surgical backup. And I do believe that intravascular lithotripsy is a safer procedure than atherectomy. But it's been a bit of a debate with us too, with regard to expanding this technology to other centers without surgical backup. And part of it has to do not with the therapy itself, but just for the familiarity of complex disease management and calcification in general, independent of lithotripsy.
Take a puff there. I'll go take a picture there. Okay, we're just going to take a little check angio here just to make sure that everything looks good. And I think the next step here probably is just to kind of, hopefully we'll be able to get the IVUS down to give us some information.
There it is.
Both about, ideally now we're looking to see, some calcium fractures in those rings that we had earlier.
I think too, with that dissection near the diagonal branch, we'll move, as long as the IVUS looks good, we'll move more quickly to stenting rather than another balloon dilatation. I can't see that wire.
So back to your point, I do think about the economics of this stuff, especially as cath lab director at a state institution. I think both the points, I do think about that a little bit in my outpatients versus inpatients when I'm thinking about IVL. I don't think any of my partners think about that, but I think about it. And then at our VA, we don't have
administration is
backup.
certainly thinking about it only because
So
it's an incremental technology with obviously a greater expense than the available atherectomy technologies. And unless you also do an atherectomy technology, then you're not really able to build for this any more than just balloon angioplasty.
So you all can see IVUS. This is live. We're recording on a pullback.
Now we're coming up to, there's the lesion. So a little more actually nodular there, huh?
or just fractured.
Oh, fractured, yeah.
I think you can appreciate the fracture there.
Yeah.
How's the diastole looking? Can you see that?
We're coming up to it here in just a moment. Here
That
it
still looks
comes.
okay on a flyby.
And then here's
So
the
do you
other.
feel comfortable-
There's a fracture there, yeah.
Do you feel comfortable stenting this now, seeing that, calling that fracture? Or are you going to prep that anymore?
Yeah, so it's a good point. I think we probably are going to be okay. What do you think, Dave?
Okay. I'd say, Eric, I'm ready to go with the stent.
What do you all think?
I don't think you're wrong yet, Wayne.
There was really no waste in the balloon when you were
Right.
doing your IVL work. So, you got the IVUS down. There was no real waste residuals, but it should be prepped nicely for the stent. Cover it with one stent, hopefully.
Yeah, we debated earlier, just estimating the lesion length. About this is going to be a 48 millimeter drug-eluting stent, which we're hopeful to cover it all in one setting.
And what were your proximal and distal reference vessel diameters? I'm sorry, I missed that.
Yeah,
Roughly 4.0 distally and 5 to 5.2 proximally.
I think stenting here makes sense. I do usually go in with an NC and just prove to myself I'm totally
There's that
content. I would
proximal
be
septal.
totally
Yeah.
comfortable doing what you're doing now,
maybe
but
forward a bit.
Yeah.
What do you think?
Yeah, I
there?
do that as well, Eric, although I do think
picture
that
there?
what happened with the lithotripsy balloon was reassuring.
Yeah,
There was no
exactly.
waste. It was fully expanded.
Okay, ready?
I understand the time sensitivity to get a stent in, given the dissection, et cetera.
I think that's right. Huh? You good?
I like
Speaking
that.
of time,
Yeah, let's take
David and Prashant, I just want to make sure you're aware, we're at about 8.5 minutes left.
Okay, so we're just deploying the stent now. 4048 stent going up here, and so far so good. Looks like it expanded nicely.
yeah,
Yeah, it looks great.
it's great.
How many atmospheres were you at when it expanded like that?
Only about 8. I'm at 12 here, and then we're gonna.
That's a good
We'll
sign.
come back and post dilate here.
I mean, your ability to deliver equipment right now is still stunning to me. That 48 millimeter stent just flew in there. So nice work with that vessel prep.
And I'm sorry, Herb. How much time left did you say we had left with you all?
We've got about 8 minutes, so I
Okay.
think if everything looks
Take
good,
the
we'll be in
40
great
and
shape. Some proximal optimization, and we'll be good.
Yeah, we've got a 5.0 for that. We've got a 4.0 for the distal component. Do you want to do the 5.0 first or the 4.0?
Then we go 40 and then come back to
Okay.
the proximal.
You want to take a
So
picture?
pull the
Yeah.
drag wire or leave it? What do you do?
Yeah, I'm glad you asked, Eric. I think there's probably variability about what people do, right? So you went to nominal on your stent. You're going to post dilate, presumably at high pressure. Will you leave that wire in the diag, or will you pull it?
Yeah, I think it's a good question, and I think it's sort of dealer's choice. When I think about this, I'm also sort of wary of the length of the wire that's underneath the strut. If it's a short segment, you may feel more comfortable going ahead and post dilating to high pressure. But when there's a longer segment involved, I'm a little more wary. But I think we're still going to be okay here.
Yeah, I read a recent study comparing the two strategies, and although the overall outcome was similar, I think that the opportunity to rescue the side branch is greater if you just leave the wire in, and so I'm ever more inclined to leave the wire in. Just be very cautious, even after high pressure post dilatation, about how we remove it and take it out.
So that's a 4.0 balloon, and you were how high,
16.
David? So we're at 16 with that 4.0. It looks like it expanded nicely. I'm going to use this just for
Take
the
the
mid
5.0
segment
then.
of the stent as well here, and then we have a 5.0 NC balloon as well ready next.
Yeah, so with these side branches being behind the stents, I have no problems keeping it in. I do opt to take a wire that doesn't have a hydrophilic coating, though, so that it doesn't strip off on the way out.
I don't know whether we asked you what wires you had down, or if you mentioned it, I missed it.
Yeah, so the LED is wired with a Minamo wire by Asahi, and then there's a run-through down the diagonal.
Our strategy is not only largely dominated by the quality of the wires, but the color. So you're on the green wire, you're on the black wire. That's
Take
kind of how we do it.
I hear you.
What's that?
It's my Martha Stewart approach with colors. I've got sage and forest green and black wires.
It works well. Well, there's actually pretty good data on the run through as a side branch wire and absence of embolizing material from that wire. So.
Thank you.
The nitinol element of the run through also makes it nice for crossing into side branches because it doesn't get as distorted and irreparably distorted when you're trying to get in, that you can stay with it, in a difficult to cross one as well.
Good there?
You want me to go there?
Yeah. I think
Before
so.
we come back? Okay.
Yeah, that's almost at the proximal edge.
We can come back just a little bit.
Yeah, that would be.
That's
good.
12 there. Okay.
It's 12, and then I'll bring it back to the.
So what we'll
edge.
do is we'll if you'll permit us, we'll dilate here, and then we're going to just keep coming back a little. I think you got like 3 more millimeters back. There we go. Right there. I'll go there.
Yeah, that's good. Go ahead.
We'll dilate this, and then we'll take a picture. And then we'll image for you, and hopefully that'll leave us with great timing. Perfect.
Great. All right. Gonna image
So Dave, this case wouldn't be obviously allowed to be in Eclipse because of the IVL. How do you think the introduction of IVL is going to impact the results of the Eclipse trial?
Well, as a steering committee member, we just recently reviewed, I have to admit, I was, we'll take a picture, Prashant, and then maybe Ivis. I was very skeptical of that trial, that I thought there'd be a lot of crossover to atherectomy alone, much less before we had IVL. And the crossover, that looks terrific. The crossover to date has been exceptionally small in the single digits, and the use of IVL has been even much, much smaller so far. So I don't think that it will influence the results of the study, at least at all.
So we're going to give you a couple minutes to get that diag wire out, and then 1 minute to IVUS.
So there was a question about whether a lima should be considered here. And just looking at this stent, I'm thinking to myself, gosh, the patency rate on this stent has got to be pretty damn good, right? You got a 5 millimeter proximal. Anybody would have considered a lima in this situation? This is an audience question, no?
That's the procedure where you surgically anastomose.
Yeah. So about the chest, I think.
I remember that. Right? I've heard about that.
Yeah.
Good.
Yeah, I mean, I think you're doing IVUS guided PCI here. You're setting yourself up for success, and there are distal landing zones, meaning you're not taking away a future option should there be an issue down the line.
I think this looks great
Single
so
vessel
far.
disease, preserved LV function, and a low syntax score. I think we can feel pretty good about standing this.
And I appreciate the question with the diabetes, and I mean, I think it's worth at least a
I think
conversation.
you always have to ask the question.
And Benita,
We'll
great
take that
comment.
wire
I mean,
out.
preserving the distal bypass.
Yeah, and in syntax too, even in diabetics, when IVUS was used and the stents were
I'm gonna take the
optimized with
diagonal
second generation
first.
stents,
Yeah.
diabetics did very well. So I'm reassured
Watch
by
the
that.
front end of
Okay.
it. So
Wow, I
Prashant's
did not
just,
think that wire would come back so easily.
and he's just being really cautious that he also doesn't distort the front end of the stent with the guide as it gets pulled in, which he did not. He did really well. And you all saw the IVUS. I thought things looked quite well expanded and opposed throughout, and there were no edge dissections too.
So Prashant, you gonna send him home today?
That's so funny that you asked that. That was my next question.
Yeah, I mean, we could. I mean, this. You want to take a puff of the guides back in, right?
Yeah.
Yeah. It's just, with this whole new COVID business and everything else, we want to make sure that he's doing okay. But he certainly, I mean, based on our result here, based on how he's doing, I mean, there's no reason why he couldn't otherwise.
Is that most people's labs doing that? I mean, I would say
Let's
our
do
lab would
that,
send this patient
Toddle
home. Is that
view.
how
Yeah.
others are doing
We
it?
would as well, Eric.
Yeah.
Yeah, I don't know if you saw our case this morning that was a left main and then an ostial right coronary stent, but she's going home as well.
Wow, fantastic.
And I'll
Would that
keep,
have changed had you performed either orbital or rotational atherectomy on this patient? Would you still send him home same day if there's a lot of work done on the LED?
for myself, I do. I even now keep the CTOs around for an extra longer part of the day, but As long as it's an uncomplicated procedure, I'll send them home same day as well. Part of this is motivated by the challenges we're having in healthcare providers, right? In hospital beds. And it's not so much the bed issue physically, it's the number of nurses and providers we have to care for these patients.
Yeah, that really sort of informs our decision a lot, right? Because, we have a number of patients who are waiting to get transferred and from other hospitals that we're trying to get in. So beds are a real premium. And I think in 2022, when you're using imaging guidance and you're able to get sort of successful results like this and confirm with imaging, you feel a little more comfortable. So even with CTOs, atherectomy, and other complex cases that previously, even femoral, even if you're going femoral access, I think you can consider it.
So David and Prashant, I apologize for the interruption. We are out of time. Thank you for sharing this wonderful case and for the earlier case as well. We learned a lot from you. We appreciate your efforts. We appreciate your colleagues and your staff as well that made all this happen. Thanks for
doing this
over the weekend to
Beautiful
educate us.
case, really wonderful case.
Thank you very
you
much.
all.
Thank you.
Great job, Prashant.
Thank you.
Thank you.
I want to thank everyone for joining this session. Hope you have a wonderful evening, and we'll see you all back tomorrow.